Physiotherapy College, Ahmedabad. So we'll conduct a session of the spinal cord injury rehabilitation. So I very much thankful for the madam for accepting my invitation for the conducting this lecture. I'll convey to the Yagna madam to continue the session. Thank you, madam.
Very good morning. Uh, First of all, I would definitely like to thank Dr. Gaurav Patel and Dr. Navjit Trivedi for giving me this golden opportunity and experience of this webinar. This is my first experience. This is my first lecture on webinar. And the best part is the topic is very much close to my heart because I worked in this field for more than 30 years. Till date, I am working with these patients. And I have tried to cover practically all the aspects of spinal cord injury related issues, points. Some points I have tried to elaborate because I would definitely like to share those experience and expertise. I would request all of you to be there till my last slide because I'm going to show you one or two very interesting case and stories. So here we are starting. I think the best medicine for COVID is stay home. Uh, this is what everyone might be wishing at this point because we all are very much inside our house and domestic, as far as domestic work is concerned, it is better to go for study than doing domestic work. Very nicely said by Albert Einstein, education is not the learning of facts, but the training of the mind to think. So I am going to let you know at the end of this is what is spinal cord injury, what are the causes, what are the symptoms of spinal cord injury, how will you assess this patient, and best thing, interesting thing, what is the physiotherapy rehabilitation of spinal cord injury patients. As I always tell my student, always start from Ekato Raja. Because even when you are going to watch a movie, suddenly the two people they are not getting married, right? They initially they show the background of both families and gradually the story starts. So that is how just a little brush up the anatomy of spinal cord. It's a long, thin tubular structure which is made up of nervous tissue. The length of the spinal cord approximately in a man, because they have more height, it is 45 centimeter, and in women it is 43 centimeter. It is extending from medulla oblongata in a brainstem, and it ends between first and second lumbar vertebrae. Just imagine the diameter of half an inch. It is so small. I have attended a spine surgery, many spine surgeries. I know it is such a small structure which you cannot even imagine. Half an inch is nothing. So the diameter of spinal cord at cervical and lumbar is half an inch, and at thoracic area it is 1/4 inch. Everyone knows there are 8 pairs of cervical nerve, 12 pairs of thoracic nerves, 5 pairs of lumbar nerves, 5 pairs of sacral nerves, and 1 coccygeal nerve. Now, what exactly is spinal cord injury? We all know that spinal cord is nothing but a bridge between brain and our limbs. If something goes wrong in that bridge, the things doesn't pass and you end up with a problem. So the spinal cord injury is exactly, always remember this, spinal cord is a bridge. So injury or damage to any part of spinal cord or nerve, chorda equina is nerve, often causes permanent changes in muscle strength, sensation, and other body functions below the site of injury. It is very important you get a symptom below the site of injury. So it depends. The clinical feature depends on the place, the level of injury, and the severity of injury. If we go through the causes of spinal cord injury, the causes can be divided, either it might be because of trauma or it might be a non-traumatic cause. Trauma is always a force on the vertebral column. It may occur, the force may be from any direction, which may result into either fracture or dislocation, or fracture and dislocation. The fracture might be with or without displacement. So there might be an extension injury, there might be a flexion injury, might be a rotation injury, it might be vertical compression injury. And there is one more traumatic lesion, that is whiplash injury. Now, whiplash injury is what? Whiplash is sudden whiplashing movement, that is when you are driving a car and if suddenly some force comes from the back side, the neck goes into hyperflexion, which the spine suddenly goes into a hyperflexion. Usually this is a cervical area where it gets injured. So, and suddenly it goes back. So the spine is damaged. There is no damage to the bone. So when the X-ray is taken, the X-ray is normal, but there is a soft tissue damage inside the spine. So that is, so patient gets symptoms, but the X-ray is normal. So that is whiplash injury. If we look at the non-traumatic causes, that is tumor or neoplasm, developmental disorder, spina bifida, uh, ischemic blood occlusion, demyelinating disease, fluorosis. Now, fluorosis is the deposition of fluorosis in the spine, which is very common. And I would like to say that out of 26 districts, 18 districts of Gujarat, they are being affected by this fluorosis. Fluorosis is in the drinking water. It's a gaseous industrial waste, you can say, that gets deposited either in the teeth or in the spine, and patient leads to this spinal cord problem. Then there is a AV malformation, vascular malformation, arteriovenous malformation, infection, tuberculosis, again it is very common, transverse myelitis. So these are all non-traumatic causes which leads to damage to the spinal cord, which is a bridge. As per one survey done in USA, the cause of motor vehicle accident is more than 50%. Even in India, I was going through one reference in 2013, one survey was done in which out of 215 patients, 112 patients were of motor vehicle accident. The motorbike accident is so common. Then comes the fall. Fall in elderly. 31% of spinal cord injuries end up with due to fall. Again, act of violence, gunshot wound, knife wound, that may lead to 13% of spinal cord injury. Sports and recreational injuries, athletic activities, diving in the swimming pool, that may lead to 10% of spinal cord injury. Out of 1 out of 4 spinal cord injury, they have a history of alcohol taking. So, because of alcohol, they lose their balance and they end up with spinal cord injury. Diseases like cancer, arthritis, osteoporosis, inflammation, again that leads to spinal cord damage. So these are the statistical data of this causes of spinal cord injury. Always remember, higher the level of lesion, more the extent of paralysis. You can see if it is C4, you end up ends up in quadriplegia. Like that, when you go down, this is the extent of paralysis. This is a nice graphic representation of complete and incomplete spinal cord injury. Very nicely this is being represented. Complete spinal cord injury means there is no motor and sensory function. It might be paraplegia, it might be tetra or quadriplegia. Incomplete spinal cord injury is there is a partial motor, partial sensory loss, and this incomplete spinal cord injury is being divided according to the place or a site of injury or into five syndromes. In the sense, Brown-Séquard syndrome is hemisection of spinal cord. So one side there is a motor weakness, and on the other side there is a sensory loss of sensation on the opposite side. Same way, anterior cord is more of motor below the level of lesion. There is a motor loss, but pain and temperature sensation as it is being carried by lateral spinothalamic tract. So that is also being lost. Posterior cord syndrome is below the level of injury. There is a sensory loss, right? Same way, central cord is more of upper this thing, more of upper limb weakness. So this is how the you can very well make out depending on the site of injury. You will get a clinical presentation and you can just know that it might be the damage to the center if it is upper limb more affected, if it is sensory then it is posterior cord, if it is motor then it is anterior cord, if it is one side motor one half side sensory then it is Brown-Séquard. And there is one more syndrome, chorda equina syndrome. So what is chorda equina syndrome? I hope I am not going too fast. Hello.
Yes, madam, you are audible, ma'am.
Thank you. So this chorda equina lesion is what? The spinal cord ends at between L1 and L2, right? Then there is a bunch of nerves. You can very well see in the figure. So this is nothing but it is a peripheral nerve. And rarely there is a complete transaction of at this level. It is always incomplete lesion. And the classical feature of this chorda equina is there is a saddle anesthesia. Now you can see that yellow on the right hand side. Saddle is there is a loss of sensation over the perineal region. So if the patient complains of this kind of symptom, then you may think of chorda equina lesion or chorda equina syndrome. Usually this being a peripheral this thing. Now, injury, the recovery is good. If we go through the signs and symptoms of spinal cord injury, immediately after an accident or trauma, the, the person may see this kind of symptoms, that is extreme pain or pressure in neck, head or back. There is a weakness or paralysis in a part of body below the level of lesion. Patient may complain of numbness, tingling or loss of sensation. Might be in the hands if it is cervical or feet or toes. There is a loss of bladder or bowel control. Patient may not be able to get up, difficulty in walking. If it is a high level injury, if it is accident, sometimes there is a impaired breathing and there is a twisting of neck or back. Maybe you can observe clinically. So these are practically symptoms of signs and symptoms of spinal cord injury immediately after trauma. And after this, once the thing is done, I mean the injury is done, again this kind of symptoms, it may be one or more symptoms. Not all symptoms need to be present depending on again site and severity of injury. There is a loss of movement, loss or altered sensation, including ability to feel heat, cold, and touch. Blood and bowel control. The reflexes are either exaggerated or absent. If there is a too much of spasticity, there is a spasm. Changes in the sexual function, sexual sensitivity and fertility. If it is higher, as I said, difficulty in breathing, coughing, and clearing secretion. So these are the usually once the injury has occurred, these are the symptoms. Now the immediate symptom is spinal shock. This occurs because there is a abrupt cessation. As I said, the bridge is damaged. So there is no connection between brain center and spinal cord. And this, because of this immediate result of abrupt cessation, there is a short-term temporary physiological dysfunction of disorganization of spinal function. So what happens? There is a areflexia, there is a hypotonia, and there is a loss of sensation. Now remember, these features of spinal cord, it starts either within 24 hours and it may last, this kind of symptoms, it may last up to 3 to 6 weeks post injury, or it may be for longer time. So the first, the, how do you know the patient has come out of spinal shock? So first sign is appearance of bulbocavernous reflex. So once that reflex comes, it means the patient has come out of spinal shock. Now, once the injury has come, now you know what is spinal cord injury, you know what are the causes that leads to spinal cord injury or damage, and what are the signs and symptoms of this spinal cord injury. Now, I am taking you through the assessment part. Again, it is very important. This is very interesting as a spinal cord is shorter than vertebral bony column. You have to always correlate in this sense. If the vertebral level is C2 to between C2 to C7, the spinal segmental level is you have to add 1. So in the, for example, if it is C2 level, you have to add 1 for the, that is C3 for the segmental level. If it is C7, you have to add 1, so it is C8 segmental level. If it is from T6, if the injury is between between T to T6, you have to add 2 number. So T3, T1 is vertebral level, so T3 will be segmental level. Like that, T7 to T9 you have to add 3, T10 to T12 you have to add 4, and for this L5 it is end of spinal cord, so there will be a presentation of sacral and coccygeal segment. Always remember that whenever lesion in the spine is examined, it is always good to mention vertebral level of injury and spinal segment level of injury separately. So you will get symptoms at C2 of C3 because vertebral level is C2 but the segmental level is C. Vertebral level is C2, segmental level is C3. I hope it is clear. So Asia, which is very common, which is a gold standard for neurological classification to describe spinal cord injury. Asia stands for American Spinal Injury Association. So what does that reflect? Because this is a very vast, very complicated thing to assess. So this is a gold standard way of assessing spinal cord injury patients which will reflect the level of injury, the severity of affection, and whether it is incomplete or incomplete, the classification of spinal cord injury. So, what is Asia? You must have seen this chart. This is a very nice, concise way, very reliable way of examining spinal cord injury patient. On the left side, there is a motor. On the right side, there is a sensory assessment. Now, motor is nothing. It is very easy. It is very fast. They have given 5 key muscles for upper limb and 5 key muscles for lower limb. And as we are doing muscle charting from 0 to 5, same way you have to assess only these 5 muscles of upper limb and 5 muscles of lower limb, which represents the root level or a segmental level. So flexors, elbow flexors represent C5, wrist extensors represent C6, elbow extensors represents C7, like that finger flexors represents C8 and finger abductors represents T1. Same way for lower limb, hip flexors L1, L2, knee extensors L3, ankle dorsiflexors. So like that you have to grade 0 to 5, 10 muscles on the right side, 10 on the left side, that leads to 50-50. Right? So total motor 100 score. If it is 100 out of 100, it means the motor is normal. Always don't forget, and it is very important to know anal contraction. Anal contraction, because this is the last part of the spinal cord which represents it. So if the last part is intact, it means the spinal cord is intact. So it is very important to know the spinal, anal contraction, uh, whether it is there or not. Same way for the sensory on the right side, yeah, it is to be graded from 0 to 2. 0 is absent, 1 is impaired, and 2 is normal. So if it is normal, then it is 2. There are 28 key sensory points in the body, so you need not to examine the whole area, but only to that black dot which you are seeing, which represent that segmental level or that dermatome level. So only that key you have to, and it is to be graded, and 2, that is, and there are 28 points, so 56 plus 56, that the total is 112 on the right side. And again, this pin prick and light touch is to be checked for the sensations. So this is how you get a sensory assessment, this is how you get a motor assessment. Again, whether it is a complete or whether it is an incomplete, for that, this Asia impairment scale. Again, please pay the attention. This complete and incomplete, it is very important to know whether it is complete, whether it is incomplete. If it is incomplete, how much is the incomplete? What is the severity of incomplete? So there are 5 grades which Asia American Spinal Injury Association has given, and which describes everything, which reflects everything, in the sense, if there is no sensory or motor function in the sacral segment, that is S4 to S5, if it is not there, then it means it is complete. Always again remember, you have to check till S4, S2, that is anal and perianal area, anal contraction and perianal sensation. Same way, Asia B is incomplete. There is a sensory S4, S5 sensation, but there is no motor function. So there is a B incomplete motor impairment that can be written, but you can say Asia impairment scale B incomplete. As you go down in a C, the motor function is preserved, but how much? Those key muscles which were shown below the level of lesion, you have to check if the below the level of lesion motor function is less than 3 out of half of the key muscles. So out of 5, if it is 3, then 3 is below grade 3, 3 key muscles below grade 3, then it is Asia C, incomplete. Then Asia D is, though these key muscles three key muscles, the sensations are normal, remember. But the key muscles, half of the key muscles are more than three, it means it is D, and normal sensory and motor function is E. So this is how you can make out complete, incomplete. Complete, usually the recovery prognosis is not good. Incomplete depends whether it is B, C or D. The recovery is uh, uh, taken place. Again, you can correlate functional abilities and level of lesion. Neck flexion C1, C2. So patient is not able to do it, it means C1, C2 might would have gone. Lateral flexion, then C3. This is how you can, depending on the functional abilities, you can very well judge the level of lesion. If the patient is not able to do elbow flexion with wrist extension, it means C6 has gone. Elbow extension with wrist flexion, C7 has gone. Finger flexion is C8. Like that, you can very well correlate the level of lesion with the movement. Same way, even the reflexes represents the segmental value. So biceps is 5, 6, triceps is 6, 7, 8, like that. So these are the deep reflexes which you need to assess. Indirectly, it represents the segmental level and you can very well correlate. Even the superficial reflexes represents it. So abdominal reflex represents thoracic 7 to 12 segments. So if 7 to 12 T 7 to 12 are involved, the reflex you may not be able to elicit this abdominal reflex. When the bulbocavernous reflex is important because you may be able to know whether the patient has come out of spinal shock. Even positive Babinski sign, it indicates the spinal cord dysfunction. So this is how you can assess sensory, motor, and you can correlate and you can judge you can make out the level of injury, severity of injury. Now comes, this is another scale basically meant for cervical myelopathy, and it is based on difficulty in walking. So if there is a cervical myelopathy, on this scale you can make out the functions scale or a severity of the problem. 0 to 5 it is being divided. 0 is there is a problem, but only there are the signs and symptoms. Otherwise, it depends how much on the walking capacity of a person, how much difficulty that person is getting, and accordingly the gradation is being done. So 0 is no problem, and 5 is patient is either bedridden or chair bound. So this is how you can assess the severity of affection of cervical myelopathy patient. As I said, complete spinal cord injury, the prognosis is poor. So recovery of spinal cord injury is challenging as far as my experience is concerned. If it is incomplete, I have seen patient 10, hardly 10 to 15% patient recovering functionally. So it is really very challenging job, and it is a great concern as far as the family of a patient is concerned. Usually, as a majority of them are traumatic, they are young, motorbike they chalata hoy. So those patients, it's a big matter of concern about their functional recovery. So again, predicting prognosis depends on the extent of lesion, level of lesion. Quadru hoy to you are not, you are helpless. If it is lower, something can be done. So once the shock is over, and if the patient shows sign of, if there is no recovery, there is no motor or sensory, I mean there is a complete loss of motor and sensations, it means there is a poor prognosis. It indicates poor prognosis. In an incomplete, as I said, if it is C or D, there is at least functional recovery. Now we are going to the main thing, that is, you know what is injury, what are the causes, what are the, how do you assess the severity and level, and now comes the main rehabilitation part. It's a very very debilitating condition, in the sense it requires meticulous effort. Always there are strategies to be done when you are treating spinal cord injury patients, and it is a multidisciplinary approach, and there is a team of rehabilitation team for the spinal cord injury patient, which includes orthopedic surgeon. Even the neurosurgeon does spinal surgery as far as non-traumatic this thing is concerned. We are there as a main leader, nurse, occupational therapist, prosthetic and orthotician, medical and social worker, again psychologist. It is very very important. Young patient, earning patient, the future is not certain, and those, it is very very common that they go into depression, they get a suicidal tendency. Urologist, plastic surgeon for the bed sore, urologist for bladder problem, dietitian, because healthy food is equally important for these people, and most important in a rehab team is patient's relative, because this is going to be a chronic condition, it requires long term care. So the confidence and cooperation of relative is very very important. So practically it is a team approach. The whole team works for making the patient independent, or helping the patient in recovering from spinal cord injury. So broadly speaking, once the injury occurs, it is important to hospitalize the patient. It is important to save the life of a patient. Again, the treatment divides into either conservative or surgery. It is being decided by the orthopedic surgeon. If it is conservative, bed rest or traction depends is given. If it is surgery, decompression and stabilization of spine is being done. So broadly, this is a chart. The first thing is to save life, and then to decide whether this patient is undergoing conservative treatment or surgical treatment. So what immediately treatment is being given? Once immediately after injury, the person should not move. In India, we have to call 108, or if it is in abroad, it is 911. Always remember, we don't have to move the injured part or a patient. Any thick firm material which whatever is available, it is patient has to be shifted with minimum movement over the spine. Patient should be shifted like a log of wood, lakdani gem. There should not be any rotatory or bending movement in the spine, and basic first aid treatment of bleeding, pain and distress to be taken care of first. So this is how the patient should be ideally shifted to prevent less damage. I must say that in 2001, when the earthquake came at our spine institute, we had 107 patients at a time of spine injury. You can imagine. So all these 107 patients, they were admitted in the hospital, but the way they were being brought with so much of precautions, and the way they were being operated immediately, there is a study done. It is being published by me, and because that was a good immediate treatment, good post-op rehabilitation, the mortality rate of this patient is so less compared to the statistical data which is being given in the of the other studies. I mean, non-Indian studies, just because the thing was taken care of, immediate part of the treatment was taken care of very nicely. So it is very important phase of patient for the patient of this spinal cord injury. As I said, surgical management is reduction and immobilization, that is close reduction with the use of screw and plate. Either bone grafting can be done. So immediate this management will stabilize the spine and which reduces further damage. These are some X-rays, survey lock, this screw and rod. So once the spine is stabilized inside, the spine is safe. So there won't be any further damage. So it depends on the severity. It depends on the surgeon whether to take a call for surgery or not. Again, posterior approach is being done for spine. Anterior approach is better, but there is a high risk of vital organs which are there in the anterior side of the body. So usually for the spine surgery, anterior approach or a posterior approach is done. As far as physiotherapy are concerned, the injury, post-injury, the physiotherapy protocol is mainly divided into three phases. It is very important कि कया phase में you are treating patient. So bedside physiotherapy, as patient is admitted. Once that phase is over, outside bed phase physiotherapy, and chronic phase or non-recurring phase physiotherapy. So broadly, this phases of physiotherapy keeps on changing the treatment strategy. We'll go one by one. As far as bedside physiotherapy is concerned, the main thing is, the main point which is to be taken care of is psychological aspect. As I said, it is very important. Counseling and reassurance. Chest physiotherapy, patient is in bed. If it is higher function, again, the chest is going to create a problem. So chest physiotherapy is important. Passive movement is important. Strengthening of unaffected muscle is important because you never know whether patient is going to recover. Yes, if you know what is complete recovery, what is incomplete, if you know the Asia scale A, B, C, D, E, you may be able to predict whether this patient will, how much the patient is going to be recovered. But still, it is always uncertain. So strengthening of whatever this muscle is very, very important. Prevention of bedside complication, again, it is very important to take care of because it may end up in, it may be a light threatening complications. So these are some pictures of bedside physiotherapy. Diaphragmatic breathing, spirometer, this is again very important. So maintenance of lung hygiene, maximum ventilation. Again, you can very well ask the patient to keep some book on the abdomen and ask the patient to lift it up so that air goes inside and indirectly it gives biofeedback, and that is how you can very well give diaphragmatic breathing. So respiration is a very chest and respiration is very important even for some patient who has a breathing problem, who has a higher level of lesion. Even PNF, chest PNF also helps. Again, you can take advantage of abdominal binder for these patients, and this is how the respiratory part is being taken care of over the bedside. As I said, passive movement, maintaining of adequate range of motion is key responsibility of a physiotherapist. So it is very important to, if it is, there is no power, passive movement to that area, the limbs where there is a power, you can give strengthening exercise. Again, it is very, very important that those muscles like serratus anterior, latissimus dorsi, quadratus lumborum, pectoralis major, rotator cuff muscles, and triceps brachii. If these muscles are there, if these muscles are normal, like in paraplegia, quadratus lumborum may not be there all the time, but majority of the cases serratus, latissimus, pectoralis, rotator cuff, and triceps. If it is there, then it is really good to at least make patient functionally independent, because pushing is the key for transferring the body from one place to another place. So if these muscles are strong enough, it helps in transfer activity even in the gait. These are the some bedside strengthening exercise, the place where the limb which has a power, that can be given this strengthening exercises. As I said, prevention of complication is very, very important. What complications this patient ends up is bed sores, chest problem, contractures and deformity, psychological aspect. Many patients have done suicide, as I said, from our institute, bladder and bowel problem, even that can lead to death. Deconditioning, if it is not in use, there is a deconditioning of muscles. Osteoporosis, bone problem like osteoporosis and myositis. Cordyceps is the commonest place where this patient gets myositis. Life-threatening complication, DVT, and autonomous dysreflexia. This autonomous dysreflexia, again, it is a life-threatening complication. Now, I am just going through one by one this complication because it is very important to know, it is very important to treat these complications. First is bed sore. You all must be knowing the stages of bed sore. So, it is very, very important to know, to prevent it right from the first stage. First thing is it should not occur. If it is occurring, if it is there, it should be prevented at earliest stage. It should not reach up to stage 4. This is a pressure sore photograph of a patient who was admitted in our institute. You can imagine the pressure sore, because the weather of India is very bad, because the condition of the economical condition is very bad in India. The patient's care is not being taken that nicely by the relatives because they have some other issues. So all this may end up with this kind of bed sore. So frequent changing of position is one way of preventing bed sores. You can put a water and gloves over the area where the this bed sores are likely to be there. Water or air bed is again another option. If it is occurred, this is a photograph of bed sore of our institute. We are giving laser scanner to just treat this, and it gives excellent results. Before this laser scanner, we used to treat these patients with UVR. So, and it is very effective, and it plays a very major role in treating these bed sore patients. If it is too big, if it is not being treated by this laser and UVR, then skin grafting is another option. It is very important to treat this because it is a source of infection. It is an open wound, and immunity of this patient is always low. So again, it may lead to septicemia. So prevention and treatment of pressure sore is important. There is one more in the USA. It is very common that they are by post. They are asking for the maggots to treat this patient. So this small creature, it eats the necrotic material, and because they move, they are sterile maggots. So they are not harmful. So they are being put inside the pressure sore, and it is being part is closed. This maggots they move, and because of their movement the circulation increases. They eat necrotic material, so that necrotic material, once it is being eaten, the healing is faster. So after 1 or 2 days the maggots are being removed. They become very healthy after 1 or 2 days because they have eaten that necrotic thing. So this is how the uh, ulcer part or a bed sore part is being treated very commonly in USA. Depression is very common. So gaining confidence, counseling, don't give false hopes. Ask, you see to it that they face the reality in a positive way. Give them an example. औरों का गम देख के अपना गम. I always do. To the paraplegic, I will show them quadriplegic. To the quadriplegic, I will show them unconscious patient. So that is how you can counsel them. But and show them the positive examples which are there in the society, so they get a confidence that even they can do it. Even pranayam helps in coming out of in taking out patient from depression. So, and you can very well enroll them in a sports activity on wheelchair, and you can just divert their mind. So these are the ways through which you can take care of depression. Even renal and bladder problems, that is a problem that is to be tackled by the urologist, but you can educate them to take plenty of fluids and ask them to take aseptic precautions. DVT, again, as a physiotherapist, it is very important to identify, because that is why you should know the eyes will see only what your brain knows. You should know the signs and symptoms of deep vein thrombosis, and if it is there, or if you feel that, suspect that, it is to be identified first, and rest bandaging. Don't give physiotherapy if it is DVT. It is dangerous. Myocytis ossification, again, it can be taken if the likely area like cordyceps, if there is a hard feeling, if there is a decreased range of motion, you should immediately think of myocytis ossification. You have to identify either through x-ray or through examination. Again, nothing is to be given rest, rarely surgery is being done. So this is how the myositis part is being taken care of. Again, osteoporosis, good healthy food and standing. Weight bearing position helps in preventing or treating osteoporosis. Very dangerous complication, autonomous dysreflexia. Again, if the neurological level is T6 or above, the patient may end up with autonomous dysreflexia. Autonomous dysreflexia is nothing but it is imbalance in sympathetic and parasympathetic uh, uh, exchanges. In the sense, if and that is being stimulated, the autonomous dysreflexia is being triggered by noxious stimulation from urinary, gastrointestinal, dermatologic, any kind of tight bandage given, that may lead to uh, autonomous dysreflexia. Even bladder distension, this patient, they don't feel the feeling of voiding of this thing, urine. So bladder distension in 75 to 80% of the cases leads to this autonomous dysreflexia. Now, what exactly happens in a patient who has a T6 or above level of injury? The bladder becomes full, it sends afferent stimulation, which is massive sympathetic response, which leads to vasoconstriction. And this vasoconstriction leads to hypertension. And this hypertension stimulates the baroreceptors in the blood vessels, and there is a crisis signal, hypersensitive crisis signal in the brain occurs. So to come out this from this hypertension, the sympathetic response, there is a parasympathetic response, but it doesn't go below T6 because there is a damage, and that leads to his autonomous dysreflexia. So, what autonomous reflexia? In what are the symptoms? Is patient may have seizures, retinal hemorrhage, pulmonary edema, renal insufficiency, myocardial infarction, cerebral hemorrhage, and it may lead to death. So always it is very important to know that this patient has end up or this patient is having autonomous dysreflexia. It is suddenly patient sweats. There is a blurring of vision. There is a headache. So if such kind of complaints comes from patient, and if it is a T6 and above level of lesion, think of autonomous dysreflexia. So it is to be identify first the source of stimuli. It might be catheter, it might be restrictive clothing, it might be straps, it might be abdominal support, it might be orthosis. All these things has to be removed immediately. So always remember it is very important to identify it, and it is very important to remove all these triggering factors which might would have led to autonomous dysreflexia. This is a small chart, but I may not be going too much of detail. It's a activity and level of lesion. So if it is C5, patient may not be able to eat by himself. If it is 6-6, may be able to eat. So this is a activities and level of lesion. It is being coincide broadly. It is not always true because so many other factors also are important. But this activities and level of this is a chart. Now once the bedside is part is over, that phase is over, patient is taken out of the bed and patient is being treated first on the tilt table. This is how the protocol which is being followed at a majority centers. So once the patient is out of bed, the tilt table starts. The reason behind tilt table is it prevents orthostatic hypertension. There is a gradual weight on the spine and patient develops confidence. Sometimes many patients may feel giddiness because there is a sudden postural hypotension. So that to prevent that, this gradual TTM is important. Now, routinely, usually, tiltable is treatment is given 10 to 15 degrees per day. So, every day 10 to 15 degrees, the tilt is increased. Patient is asked any symptoms about giddiness or uneasiness, and gradually it is being tilted further. So sometimes even some patients they are being progressed fast. So fast TTM is being given 30 in 3 days. Patient is in sitting position. So this is what the tilt table is. The angle is being measured. So every day 10 degrees. It is very important. This prevents the orthostatic hypotension also. And once the 45 degree of tilt table is being reached, patient can be made sit in a bed with a back support. And after 90 degrees of tilt table, patient is shifted or the wheelchair activity or wheelchair protocol or wheelchair is treatment is started. So once the patient is allowed sitting, rehabilitation is started, the mat exercise, transfer activities, strengthening, standing, balance, gait training. So at the bedside, outside the bedside, once the TTM is over, patient is taken for mat exercise, transfer activities, strengthening, standing, balance, and gait training. Now, mat exercise, very important, very effective, and patient feels secure even patient doesn't fall down, so you are secured. So preparing the patient, and that prepares the patient for independent mobility. So mat program should be initiated, progressing the patient from rolling to various higher tasks such as sitting. Even in the mat exercise, you can start PNF technique, and that facilitates the mobility skill. Rolling is the first thing usually taught on the mat, so that the turning helps the patient for preventing bed sores. So it is very important to teach this patient turning of body on mat. These are the some photographs of mat exercises. It is really helpful, crawling, kneeling, even sitting with the hand. So the balance is gained, patient's confidence is gained. So even the weight bearing in on a crawling, it can be treatment can be given. So these are all mat exercise on mat. Very important. Very important. I would emphasize this transfer activities. As a physiotherapist, you should know how the transfer activities should be taught to the patient, because this is the thing which will make patient mobile, which will help the patient to come out of the bed, and which will help to make the patient independent. So transfer from bed to wheelchair in a sitting position is very important. You have to prepare the patient. Patient is asked to lift and patient has to descend. These are the three phases. For that, pushing from the upper limb is very important. As I said, latissimus dorsi, which is a muscle which which connects upper and lower part of the body. It is a big muscle. So pushing through serratus anterior, triceps, this latissimus dorsi. If it is strong enough, it will be easy for patient to push himself and uh, uh, lift himself up from the bed. So transfer from bed to wheelchair, from wheelchair to toilet seat, it is being taught. It is very important to know the hand movement, the grip movement, where to place it, how to pivot it. So in the first figure, the patient is preparing himself for the transfer. Patient is pushing himself with the hand to get up, pivoting himself to shift his body through to the bed, and patient is shifted. So this is how the whole process. The stability of wheelchair is equally important. There should be a brake over the wheelchair. If it moves, the patient may fall down. It is very important to take care of that aspect. It should be sturdy enough to bear the weight of the patient, and this is how patient is being transferred. Same way, transfer from bed to wheelchair, or this is a sliding board through which patient can slide him or herself from bed to wheelchair, from wheelchair to bed, and it really helps and reduces relatives and patients' burden, because once a patient slides either in the bed or in the wheelchair, then it is very much necessary to have this sliding board and teach the patient how to slide on the board. As I said, strengthening is very important once the patient is out of the bed, because you never know how much the patient recovery is going to, how much recovery patient is going to have. Again, over and above latissimus dorsi and serratus anterior, quadratus lumborum strength is very important. You can very well stress, you can give more stress on lumborum, because if the lumborum is there in a gait, even though there is no muscle power in the limb, with the help of orthosis, patient can be made to walk, so that if the lumborum is good, there is a hip hiking, so the ground clearance becomes easy and patient can be made to walk. So latissimus dorsi strengthening, as I said, on the wheelchair, it is in the sitting position, it is very, very important. Again, this is a hand ergometer. So the exercise is being given for upper limb on this ergometer. The strength, I mean the resistance speed can be changed, and it is very, very helpful in strengthening of this upper limb. So even the pushing on the wheelchair, lifting of the body, so it will prevent the pressure sore and it will strengthen the muscle. You can increase the number of repetition. So this is how upper limb strengthening is being given. Even for the crutches, practice can be made. So these push-ups can help. As I said, lumbar arm strength is very, very important. So you can focus on lumbar arm strength, and this is how body can be lifted up with the lumbar arm, and you can shift it and you can make the patient walk. Many patients, majority of the patients who are completely paraplegics, but if they are young, if they are little thin in body, and if the lumbar arm is good, they are managing very nicely even though they don't have any lower limb power. So it is very important. The quadratus lumborum is very important muscle as far as this paraplegia is concerned. As I said, standing in frame, again patient can do this in a standing frame. This is a wooden standing frame, and there is a belt over the which is fitted at the posterior side, that is ischium side, and that will not let the patient to fall down even on the anterior side over the thigh. So mechanically that the body is fixed and patient is able to stand even though there is no muscle power. Again, very important, very interesting, this is a gait trainer machine. We have this in the machine in our department. This is how the patient is hanged, and the things are being, the patient is not doing anything. This is like CPM for the gait. The passively the things are moving as if patient is walking by himself. The speed, stride length, everything can be you can very well control it, and gradually then patient is asked to make his own effort with the machine. So the thing is moving, it is walking, and patient himself is trying to push. So that is how the gait training is being given with the gait trainer machine. See this lady, how nicely she is managing, even though his muscle power is not that great. Great. Very, very important. Like transfer activity, wheelchair training. Nowadays, personalized wheelchair is being given as per the patient's height, as per the patient's width, as per the patient's can operate it by himself. So this is very, very important that this wheelchair training is being given so that the patient becomes independent in a standing. Like on the right side you can see there is a machine uh, which fixes the wheelchair. Patient is made on the wheelchair, made to sit on the wheelchair, and this is how the patient is taught how to do rolling, how to go for the forward, backward, uh, how to propel forward and backward with the wheelchair. Even they can cross the ramps and slopes with the wheelchair. For that, upper limb power is equally, I always give more stress in strengthening of this upper part of the body in a paraplegic patients. If the recovery is stagnant, when we know, especially in a paraplegic patients, so patient, there is a stretching strategy. The patient, if patient does not recover, then patient is encouraged to have a short, long finger flexors so that the advantage of tenodesis grasp is taken care of. As I said, Each and every patient is different. For each and every patient, the strategy of the treatment is different, the planning is different. So many factors counts. So this stretching strategy, passive grasp and release mechanism is encouraged. Same way for lower limb, even the tendo Achilles shortening is encouraged. So floor reaction orthosis, it's like for floor reaction orthosis. If the tendon Achilles is short, it helps in a patient to walk. So these are indirect way of making patient functionally independent, not ideally, but looking to the scenario, looking to the circumstances, patient is being encouraged this way so that at least that part is being helped indirectly for the functional activities. Again, group therapy. This is a photograph of our institute. This is a group therapy which is every day in the morning. It encourages, it gives lot of solace to the patient that that patient is not alone. Even it creates a sense of competition. So it is very very important and it helps a lot as far as group therapy is concerned. Again, this is another photo. Aquatherapy, plays a major role. The only limitation of aquatherapy in India, the maintenance is very high. We have to take care of infection. The patient should not have open bed sore, otherwise it is not to be given. Skin issues, it is not to be given. Sensory issues, it is not to be given, or it is to be given with proper caution. But if the facilities are available, it gives excellent results. Nowadays, aquatherapy is new therapy in a many physiotherapy institute. Even in Ahmedabad, there is a aquatherapy institute. So even in the swimming pool, it can be given, but it should be given with lot of precautions because these patients are not normal. This aquatherapy, why it is so good? It reduces spasticity. It relaxes the muscle. When the buoyancy strengthens the muscle. It's a unique medium for neuromuscular re-education. It allows freedom of movement. And because the patient is surrounded by water, they feel sense of security. So fear of falling is decreased and the patient's confidence increases. So it is really good, but there are certain limitations. So turning in bed, transfer activity, standing, wheelchair independency, and self-catheterization. This is the key of for the to make the patient independent in a patient of spinal cord injury. Just I am quickly going through the types of bladder and what is to be done. Spastic bladder. As we all know, always remember bladder is like a balloon. Balloon is the inflated part is a detrusor muscle, and the point of entry of air is a your this um, sphincter muscle. So if the sphincter muscle is tight, detrusor muscle is relaxed, it is good. When you evacuate the bladder, the sphincter muscle has to be relaxed and the detrusor muscle has to contract. So remember this balloon, detrusor muscle, there is a air, that is urine. Sphincter muscle keeps the air inside the balloon. If the air has to go out, sphincter muscle has to relax so that the urine comes out or air comes out like that. So what happens in spastic muscle? The sphincter muscle and detrusor muscle both are hypertonic. So the capacity of urine retention is less because the detrusor muscle is all the time is hypertonic. Sphincter muscle is also hypertonic. So it is very difficult to take out this urine even though the patient tries, only small amount comes out. So this because of the bladder and external sphincters are not in a synergic way, because of this dyssynergia, it leads to problem, and that is spastic bladder. I hope I am clear. right? So voiding part is really difficult in a spastic because the capacity is less. All the time the muscle is contracting and the detrusor, I mean the sphincter is not relaxed. So it is difficult to bring out urine. Opposite thing happens in a flaccid bladder. The muscle is relaxed all the time. The urine keeps on gathering. So it is always, you have to see to it that it comes out through catheter. So because of the damage to sacral spinal cord at the level of reflex arch, there is a loss of detrusor muscle tone and patient ends up with flaccid neurogenic bladder. So the flaccid, these are the ways, Crade's method, tapping method, and Valsalva, through which the flaccid bladder can be trained. Very important self-catheterization. You can see on the pink in the pink photo there is a mirror in front. It is being tied so that it gives guidance, and patient is taught in our institute also like this. Mirror is given and patient is taught self-catheterization. Again, bowel dysfunction is again an issue. It is difficult to evacuate. So, Valsalva manual, abdominal massage, manual evacuation, suppositories, laxative, digital stimulation. All this can be given for the bowel dysfunction complaint. Orthotic support plays very important part for the functional environment. Braces, splints, walking aids are given. The only thing is because of this wear and tear occurs, the changing of splint is very much necessary. So servicing, repair and maintenance, it requires services, maintenance and training. These are some orthoses, toe raising splint, uh, knee guard, and patient has worn. Without any muscle power, this patient is walking very nicely. So this is how you can make patient walk, mainly through quadratus lumborum. These are the some changes which are needed in the house because this is a chronic condition. Patient is majority of time not going to recover. So these are the floor should be not slippery. There should be handles. Some patients they do changes by themselves. These are the rows this patient had made it so that he need not to call anybody in the house and he can get up by himself. This is how the patient uh, they change themselves. These are the certain tips patient has to take care of when they are going home. Because of sensory problem, they have to keep on checking with the mirror where the bedsore, whether the bedsore has occurred or not. They have to be extra careful in eating. They have to be extra careful when they are touching the hot thing. So these are the certain areas which are to be taken care of once the patient is discharged. Even while cutting their nails, when they are sitting on a floor, they have to see to it that it should not be hard. They have to keep a pillow. The bed sheet has to be very without any creases. Patient may have problem. Patient is asked to stand up as far as possible, maybe with the support of chair at the home, on the wheelchair. So these are the certain points which are to be taken care of to prevent other complications. Even the vocational rehabilitation is very important uh, because patient ultimately has to be made independent vocationally, and that self-esteem has to be maintained. It is very important to give vocational rehabilitation. These are the certain vocational things which are being given, and patients are really, it is helping their family and the patient. Even in a sitting position, this mehndi making can be taught, and patient can earn their livelihood. Even the patients are being taught beauty parlor things and they are earning. So many things can be done on a small business, vegetable, fruits, even occupational therapists, plays a very major role as far as the upper limb problem is concerned. Even transfer activities, they really teach how to transfer, how to do transfer activities. And as far as upper limb are concerned, for skill movements, occupational therapy plays major role. As I was saying, I wanted to tell you some story. He is a Dr. Ted Rummel. He is an orthopedic surgeon. He had a cyst in the spine, hemangioma, cyst filled up with the blood. And in 2010, he came to know that he has this problem. He was afraid of the surgery and it got burst and he ended up with paraplegia. So he was quite depressed naturally, and being an orthopedic surgeon, he had this problem. So what he did, after 2 years of vigorous rehabilitation, one day he realized that nothing is wrong in his head and in his hand. So why not to take advantage? And he developed standing wheelchair. You can see in the photograph. So he developed this standing wheelchair and he started operating. First surgery, it was being monitored and assisted by the other surgeon because you never know, in between he may need some help. So this is how you can see on the right side there is a shoulder. So he is an expert of this arthroscopy at shoulder joint. This is a photograph of first day when he came out of operation theater and he met his wife, because that first surgery created a lot of confidence in him. And now even today he is working and with this standing wheelchair and he is operating patients. So this kind of examples motivates such spinal cord injury patient. Whatever skill they have, they can very well continue it with some modification. Same thing in India, he's a Sandeep Kumar. He's working at Delhi airport as a public relation officer. If you happen to be at Delhi airport, you can very well see him working very nicely. He was the first one to appoint as a paraplegic in a government service at the airport, and very efficiently he is working. Again, this is a Mukund Bhai. He was working at our institute. He was a spastic paraplegia with bladder and bowel involvement. He worked at our institute for 25 years. He used to come on this motorized tricycle, and he was managing himself very nicely. So at our institute, we always used to give this him as a best example, and it used to give lot many motivations to our patients. This is what I wanted to show you. This is a patient who came to our institute, stab injury patient. You can see that stab has gone inside the spine. This is a patient. You can see that stab on the back side. We had initially he was to lie on a prone lying position because it was inside. This patient, if we look at the X-ray, we may feel that patient might would have ended up with quadriplegia. But fortunately, to his good luck, he had incomplete cord lesion. So he had a functional muscle power in all four limbs, on which now he is walking very nicely. But if you look at this photograph, you can you may think that this patient has might not be having this power at all. This is a robotic device, exoskeleton orthosis, which runs on a motorized. It is a sophisticated orthosis. And it is not routinely, can be afford, or it can be routinely used in India, but it is very, very commonly used outside India. Uh, Again, passively, this machine makes the patient walk. So, again, this is my favorite slide. Rehabilitation or restoration of human function is my concern. I am a physiotherapist. I would strongly recommend you these two books. I'm a co-author of this Management of Spinal Cord Injury by Physiotherapists from Site to Settlement. We are the three authors, Dr. Dilip Bhai Patel, Dr. Anjali Ben Visse, and myself. And another book which is being released last month in IAP conference, Principles and Practice of Physical Rehabilitation. I have written a chapter on spinal cord injury, chapter 28. You can very well refer this chapter. And if you have any queries or any questions, you can very well write it to me. You can Google me, Yagna Shukla, www.yagnashukla.in, and uh, that is it. I hope I have. Uh, these are some questions which I thought you may would like to know what kind of questions may be asked. You can copy it down.
Good morning, ma'am.
Good morning.
Yes, ma'am. It was really a great session, ma'am. And me, myself, Dr. Navjot Trivedi, I'm Dean and Principal of Parul Institute of Physiotherapy, Parul University. And Dr. Gaurav Patel, sir, the Principal of Ahmedabad College of Physiotherapy with us. And Madam, thank you so much for organizing this wonderful lecture, webinar. It was not at all looking like you are doing it for the first time, like you have a great
No,
experience of
it was
doing.
wonderful experience for me
Yes,
because
because what we saw, the way your speed was very understanding and it was going very clear and matching, and
thank
it
you.
was so nice for us to understand whole session. I really want to ma'am thank that you went from detail, from basic till the advanced level physiotherapy management can be given to the spinal cord injury patients, all kind of complication. Also, you discuss Western scenario, what is happening in Western scenario. The doctor's example was really amazing, and also in Indian scenario that
Yes,
if the person is having really motivated and courage, he can really live a very good life with spinal cord injury, ma'am. That is a really great message. And the important thing is our role as a
yes,
physiotherapy, right,
yes,
ma'am?
yes,
Ma'am,
yes.
what do you suggest? How we can, like, we are new, and number of people, those who are listening us, they are new. How to develop that confidence in a patient? Because most of the time now, patients and their relatives are very much depressed. So, ma'am,
Yes.
how do you do that, ma'am? Can you little bit explain on that?
The thing is, it is always expected that the patients and relatives are worried. To gain their confidence, it is very important to show them some examples. With the examples, their confidence increases. That is what we have seen.
Yes, ma'am. Hmm. Hmm. Hello.
So,
Hmm.
am I audible?
Yes, ma'am.
Yes, yes, madam.
So, the gradually, because this is not a one day job or this is not a 1 week job, gradually, even patient, they start accepting the reality and they start motivating or molding themselves according to the scenario. At
Ji,
the
ma'am.
same time, it is very very important as far as the relatives are concerned. So rather than gaining confidence of patient, it is more important to gain the confidence of relative, because everything depends on them. Patient is also depending on them. Even the prognosis also, it makes lot of difference. If the cooperation understanding of relatives is very good, then the patient can come out very nicely. So the approach attitude of relative is more important than patient's own, because automatically that comes if the relative is cooperating and understanding. Automatically the patient is going to get good confidence. So, and
Thank
we motivating some movies. Even at our institute, we show them some movies. We do sports activities. We always try to involve themselves in many activities. Even they play carom, they go out. They see many. I mean, uh, to divert their mind
Yes,
continuously
ma'am.
by just making them lie on bed and thinking about their future is not a good way of managing these patients. So you have to motivate them. And really, it was really challenging for us when 107 patients at a time came to our institute.
Oh.
That was
Mm-hmm.
a lifetime experience because we ourselves were not confident and we have to treat these patients, but we have good memories of those patients because we have seen them improving, we have seen them going back to the society. So, and this changes and this vocational, it helps them a lot, this vocational
Mm.
motivation, because when they start earning, even the family members give them importance.
Okay, yes, ma'am.
So
True, ma'am.
sewing machine, things like sewing machine, this mehndi making, that keeps them going.
Right, ma'am. Right. So they
Right,
they
ma'am.
they are encouraged to do their self. They take care of
Yes,
their self. They are earning for them, earning for
yes,
family. That motivates everybody, and they become
yes,
lot of confident, ma'am. That's
yes,
really really great, ma'am. Ma'am, what about rural patients? Those who are coming from rural area and urban area, is there any
yes,
specific
yes,
difference we
yes,
take
yes.
care as a
You know,
physiotherapist?
yes, yes. There was a program, that is Safari program, where our rehab team, we used to go to patients' home for follow-up. So those patients who had very much, they were there in our institute. Once they are discharged, once they go home, we go there to their home for the follow-up, and we have seen the it depends again the education, the economical part, how much care they take care of these patients, but majority of the patient they take good care, but the only thing is our weather, this hot weather, the and
Mm-hmm.
lying in a bed. But from our institute, usually the nowadays this water bed is being given when the patient with the patient when they are discharged. So even that part is being taken care of. Some patients they make intelligent changes in their own house. We have seen them,
Okay.
and very nicely they are managing. So we take those examples and we even guide the other patients also that you can do make this kind of changes. Even they cook by
Okay.
themselves.
Mm-hmm.
Yes,
Mm-hmm.
yes. They make a nice sitting arrangement, and in a sitting position, they even cook. The platform
Right.
level, they make it at their level, and even because this is a now they're going to be their routine life, so they have to accept it and they have to act accordingly.
Very true, ma'am. Very true. That is very important. Even community care is important,
Ah,
ma'am.
but
Ma'am, in
they
international or national organizations working behind specifically behind spinal cord injuries are there? They
many.
get kind of many
Yes,
other.
yes, yes, yes. Even I would like to enlighten you that even the earthquake victim patients, they are getting every month to 2,500 rupees every month. All patients who are still there, you will be surprised that out of this 107,
Mhm.
this is after 19 years. There are 68 patients. They are still alive. Three patients, they
Okay,
delivered
great.
a child. These are quick spinal cord injury patients, and
Mm-hmm.
many patients they are on their own vocationally. So
Amazing.
it is really
Really very this thing
remarkable
impressive and their
because
lifestyle
this
has improved. Yes.
2,500 makes a lot of difference.
Lot of difference in their life. I
Yes,
agree,
yes.
ma'am. Thank you so much, ma'am. We are
Thank
so
you.
glad and we are thankful from Ahmedabad Institute of Physiotherapy, Parul Institute of Physiotherapy, and Parul University as a whole. You know, taking webinar is like you are talking to the computer. But actually,
Exactly.
there are a number
Sir,
of people, those who are understanding and learning from us, staying, we are maintaining really a social distance and doing a learning process. Thank you so
exactly.
much, ma'am.
Yes.
Right.
Thank
Gaurav
you.
sir,
Thank you, Gaurav.
Thank you, madam. Thank you so much. It was very wonderful session, madam.
I should thank you for giving me this wonderful experience. Thank you.
Thank
we
you,
will
madam.
like to tell our
So,
viewers that this whole episode will be published on YouTube. We will be sharing the link. So if you have missed some part of this, you can always see from the YouTube, and we will be sharing that link from our institute.
yeah,
Gaurav
I
sir,
will
that's
share
all.
the link. Yes. Yeah, we will
Yes.
Thank
share
you.
the link. Okay. Thank you. We are ending this session.
you so much,
Yes.
ma'am. We are
Yes.
ending the webinar now. Thank you so much.
Thank you very
Thank
much.
you, madam. Yes, madam.
Stay home, stay safe. All the best.
Thank you, madam.
Thank you.